Thank you very much. So welcome everyone to this webinar, Let's Code Together. My name's Jane Knight and I'm a clinical associate with the MSSO, and I'm joined today by my colleague, Dr. Caroline Wilson, who's one of our medical officers. I'm just putting my camera on and I can give you a wave before we start. There we are. Hello, everyone.
Hello, everyone.
The first slide just explains that MEDRA was an ICH initiative in the mid-1990s. The MSSO was put in place to maintain and distribute MEDRA, and the activities of the MSSO are overseen by a management committee with representatives from the industry and the regulatory authorities across the ICH regions. The next slide explains that as MEDRA is owned by ICH, so is the material we're going to use today. That you are welcome to watch the presentation back. We will be recording the presentation, so you're welcome to watch it back. But if you do quote anything or use anything from it, you must acknowledge ICH as owners of MEDRA and the material. So we're going to make this into a workshop format. Some of you may have been with us before, so I'll go through this quite quickly. We'd like you to use the questions panel to ask questions and comment. We do want to hear your comments so that it makes it in a workshop format. We're not able to meet face to face, so this is the closest we can do to have interactive activities and classes. Sometimes we may not all agree on the terms and what we think is the best term to choose. So we will have some discussion, but if we do get to a stalemate that we don't agree, we may have to agree to disagree in the interest of time. And if we have any complex questions that we can't address, we will follow up with you with email after the session. We cannot take requests to code specific verbatim terms via the questions. That's an important one. We are interested, though, in if you have suggestions for future verbatim terms for us to use. And at the end, there will be an option for you to propose new examples for consideration. But please do make these of general interest to the wider audience. So as I mentioned, we want to make it interactive. One of the ways we make it interactive is by using a poll everywhere software. And this is something that you can log on to either with an internet browser or your computer or your cell phone. And you go to the URL bar at the top and you type in pollev.com. That's all you type, pollev.com. It will take you to the Poll Everywhere software, and you need to enter the username as my name, Jane Knight 855, all one word, Jane Knight 855. This will allow you to link up to our presentations. Who says what? So I'll just give you a minute. I tested it before and it was working, so I'll just give you a minute there. Okay with everyone? If you do forget, the details are in the chat. I can see a lot of you have already managed it. Well done. What do we got here? Tunisia, Spain, UK, like me. Caroline, Russia, Korea, South Africa.
Dublin, Spain, Buenos Dias, UK, South Africa, Philippines.
Philippines. Wow, welcome everyone, wherever you are in the world, welcome.
Middle East.
Mexico.
Venezuela. Venezuela, Buenos Dias.
Ah, yeah, I know there was someone on the list from Mexico. That's why I say Mexico. Venezuela, welcome. Maybe it's good.
Tunisia.
So then we say what we've done is we've given you now a demo web-based browser access. So the password's not very easy to remember or copy. So I would suggest you either take a photo of it with your mobile phone, or Caroline has put it in the chat for you. So if you do need access to a browser, you can use this. The username is training, all lowercase, and the password is that on your screen there. So take a photo. If you haven't used the web-based browser before, you go to our website, and if you see there, it's the top right-hand corner, there's a link to the web-based browser. Okay. Let's get moving. So coding can be challenging. There's not always an exact match, and sometimes there's more than one possible approach. Even the PTC document, the points to consider document, sometimes gives us options for handling a particular type of term. And sometimes we understand terms differently. So the best we can do in coding is to look for the closest LLT, and sometimes it isn't an exact match, and we have to make the best approximation. But overall, we always code as reported without making assumptions. And this is why, if you've been with us before, you'll be familiar. We always bring one of these along. This is what we see as being an ambiguous picture. Now, you might be looking at this one and say, well, why is this ambiguous? And if I were to ask you, is the gentleman walking towards us or away from us? What would you say? We could probably do a poll on this one, and half of you would think he's walking towards us and half would think he's walking away from us. But so, and well, this is, we include this because to me, this is what coding sometimes is like. We don't always see the term in the same way, and we need to use some medical judgment. So coding overall is a balance between following rules, which give us consistency in coding, but also using medical judgment to manage the risks to patients. Medical references are helpful for us in making decisions, and sometimes even with medical references, it's not possible to find the right term in MEDRA, and you have to add a new term, ask for a new term to be added via the change request process. So having said all that, I'm now going to turn my camera off so that we can all relax and focus on the session, and let's code together. Caroline, would you like to take this first one?
Yes, I tried to share my screen, but it's not working. You have to make me presenter.
Let me make you a presenter then. Bear with me. There we are.
Here we are.
Great.
Let's start with our exercises now. The first verbatim was actually proposed by one of the participants of a previous Let's Code Together session. And what is reported here is a palate mucosal irritation. So in order to find a suitable term, we will need a clear understanding of what irritation means and where the affected body site is exactly located. What LLT assignment would you propose for this verbatim? Oral mucosal irritation. Yes, it's the mouse that is affected. Any other proposal? It's always worthwhile to look irritation. So most of you seem to select oral mucosal irritation. Thank you for joining again. So first, let's look at the exact location of this oral irritation. What is meant with the palate is the mucosa in the upper part of the mouth. So this part of the mouth is affected by the irritation. You see it here, the hard palate, soft palate. So the roof of the mouth, the upper part of the mouth is affected by the mucosal irritation. Now, how are the irritations of specific body sites handled in MEDRA? How is this term classified in MEDRA? So let's look into the browser for searching here. The session has timed out. I have to log in again. If I enter irritation into the browser and I search, I will get quite a number of search results, 63 in total. And you see that there's a lot of terms, bronchial irritation, for example. Here the irritation is represented on PT level. We have corneal irritation, again on PT level, eyelid irritation, gastric irritation. Here the irritation is represented under a discomfort PT. So somehow irritation is handled differently in MEDRA because MEDRA does not apply one single rule for classifying such concepts, but really also applies medical judgment. So if we look for irritation gum, so here we are approaching the oral area, then we see that irritation gum is represented under gingival discomfort. Irritation lips is represented under cheilitis. So here the irritation of the lips is considered an inflammatory process. So there are different classifications. So in order to narrow down our search a bit, because we have many potential hits, I will select gastrointestinal disorder SOC and search again in order to restrict my hits here to the gastrointestinal concepts. And here we see that we have an mouth irritation, oral mucosal irritation, but we also have an irritation roof of mouth. So here with this oral mucosal irritation, we would capture the mouth, but we would not capture the exact localization in the mouth. So if we would choose the irritation roof of mouth, this would be a more closer match to what has been actually reported. And if we now do a right mouse click on this specific LLT and say go to browser, we can explore the PT and all the LLTs underneath, and you will see that there is another LLT available that is palatitis. So here you could also select palatitis. With palatitis, you would lose the wording irritation, but you would capture the exact localization of this irritation. With the irritation of the roof of the mouth, you would also capture the upper part of the mouth, and you would capture the exact wording of the reported condition, that is irritation. So this would be my preference. You see how granular MedDRA is, so there's always choices. It's always worthwhile to really check the LLTs under specific PTs to look for even more appropriate, more suitable terms. Let me switch back to my presentation now. Here we are. So what are our learning points here? If not sure how to interpret a medical term, like in this instance, irritation, it is always helpful to do a bottom-up search in MedDRA to better understand how the respective term is classified in the terminology. And if you then find a somehow suitable PT, browse top-down to see if there is a term that captures the affected body site even better. And you should also consider synonyms, as we did in our example here, where we replaced palate by roof of mouth. And here again, the suggested code assignment, namely LLT irritation of roof of mouth under PT stomatitis. But of course, also palatitis would be an option. It's more or less a 50-50 decision. Next example. Here, eye twitching is reported. Now, how can we capture this verbatim? Is this clear enough? What do you think? How would you handle this report? Eye twitching. So you would consider this a blepharospasm, so an eyelid twitching. Eyelid twitching, yeah. So far we have eyelid twitching. Would somebody query in order to find out what is actually meant? What would you do? So most of you tend to code this directly to eyelid twitching. Again, thank you for joining. Thank you for submitting your proposals. Twitching facial, different approach. It's more broad. Let us look in the browser again. Let me switch back. And I will enter eye and twitch and search. No. Sorry, I made a mistake. I am warned here, SOCs are limited in the search to one SOC, namely gastrointestinal disorder. I will have to first clear the selection. This is what often happens, but you're warned. So if you don't find any hit for a search entry, and this is not what you had expected, make sure that you didn't narrow down your search by selecting specific socks for your search. Here we have it, eyelid twitching. So we only get one hit for our search, eye twitch. It's eyelid twitching that is grouped under blepharospasm. But can something different be meant here? Let's check. Let's get back to my presentation here. Well, eye twitching could mean different things. Most frequently, and most of you have proposed this, it will describe eyelid twitching. But as you can see on the website of the Mayo Clinic, eye twitching could also describe a twitching of the eye itself, the eyeball. Although one has to admit this is reported quite rarely. It can be a sign of a neurological disorder, and you see some on these neurological disorders on the slide, like cervical dystonia, multiple sclerosis, Parkinson's disease, Tourette syndrome. But eye twitching may also be a side effect of drugs, so the twitching of the eyeball itself, like for instance of medications used for Parkinson's disease. So somehow eye twitching is an ambiguous term. In most instances, I agree with you, eye twitching will relate to eyelid twitching, but it really depends on your study population if you're working in clinical studies, or on your respective product, whether this is really true, because it may be that a report on eye twitching really relates to a twitching of the eyeball. The twitching of the eyeball results from a dysfunction of the 6 extraocular muscles that you can see in this illustration here, and they are innervated by 3 different cranial nerves, and a neurological disorder affecting these cranial nerves then may lead to eye twitching, eyeball twitching. So in summary, you should be clear whether such a report truly refers to the eyelid or whether the eye itself, the eyeball, is affected by the twitching. Based on your company specifics, like your therapeutic areas, your products, you may come up with your own detailed coding conventions for coding such a scenario. So, and you may decide to either code to eyelid spasm, or rather consider this an eyeball twitching. But in case of doubt, you should rather query. Finally, we suggest the following. Because eye twitching is an ambiguous term, it should be queried, usually. But based on company-specific considerations, you may also decide to code to either eyelid twitching, blepharospasm in all instances, or to code to eye movement disorder, or to extraocular muscle disorder. But document your rules in your internal coding conventions. Train your coding staff accordingly and ensure that these rules are then applied consistently. And with this, I give back to Jane now.
Thank you, Caroline. We've had one question come in, a comment really on your first example that you took us through. Mm-hmm. The comment from Sophia was, well, shouldn't we stick with oral mucosal irritation and lose their palate, because that's the closest wording to what's been reported? You went for the palate, a roof of mouth irritation rather than oral mucosal. Could you just explain why you thought yours was better?
Yeah, because all these LLTs are grouped under the PT stomatitis. So an inflammation of the mucosa of the mouth. So this already captures the fact that it is a mucosal inflammation, irritation, so to say. And then I would look for the LLT that best captures also the specific site that is affected within the mouth. That would be my approach. You would capture it with palatitis.
Thank you. Another comment's come in. Could the eyelid twitching be coded to oculomotor spasm?
Oculomotor spasm. I would need to check where LRT this is and where it is grouped under, what the PT is.
Okay. We'll maybe shall I have a look when we're next in the browser? We'll hold that thought and we'll come back to it,
Yeah.
Valentina. Okay. So thank you, Carol-Anne. Let's move on now then to our next example. Hopefully you can see my screen. This is a 0.5 centimeter jugular lymph node. So what's being reported here is this, it doesn't look like a diagnosis. Is it an investigation finding? Is there even an abnormality here? And how do we capture it accurately? Well, those of you that have been coding for a while may well have seen terms like this quite regularly. It does sometimes get reported just listing the lymph node, which we've all got lymph nodes. So what does 0.5 centimeters mean? So let's have a look. Let's have a look first about the site. So jugular, are we clear where this lymph node is being reported? It's 0.5 centimeters. So I would start to think that it's maybe been felt on palpation, on some physical examination, it's been felt. The lymph node, you don't normally feel them as being, there must be some problem with it. It's probably enlarged, or the suggestion that there's something wrong with it. So this is where the jugular vein runs. On this diagram, you can see the lymph nodes that run along the jugular vein. So we know now that it's in the neck region, or we could say cervical, but that's the kind of region that I would have. If I were to do a poll with you, which of these LLTs would you select? Are we saying that it's abnormal on a scan, a biopsy, that it's a lymph node disorder, lymphadenopathy, or an unspecified non-infective disorder of the lymphatic channels? Which of those would you select? So let's go now and see what you've voted for. So most of you have gone, it seems like it's a split between lymph node disorder and lymphadenopathy cervical. Seems like few of you would go for a scan, although there's no scan or biopsy mentioned in the verbatim. So we seem to be, most of us, collecting around lymph node disorder or lymphadenopathy cervical. Now, what would be good? It would be nice if I were able to say to you, well, why did you not choose lymphadenopathy, or why did you choose lymph node disorder when one's got the cervical? What do you think lymphadenopathy means? Now let's have a look in Medra and see what we can find. So I'll go to my browser. So I may need to go and I'll go to the Medra website, open my web-based browser. Here we are. And let's have a look then at lymphadenopathy or lymph node disorder. Lymph and disorder, let's have a look at that. That's what you said you would choose. Let's have a look. So we've got lymph node disorder, we've got other lymphatic disorders and other disorders of the lymphatic channel. But as we've got node mentioned, let's have a look at the node and let's go to the browser, and I can see immediately there that it's actually under tonality that sits underneath lymphadenopathy. So there it is, lymph node disorder is under lymphadenopathy. But if we were to say, well, if it's an LLT there, it must be a synonym or a close related subconcept of some sort or similar. So lymphadenopathy, if we break it down, all that means is lymphs first, adeno, meaning gland or node, lymphadeno, and opathy, meaning disorder. So all that lymphadenopathy means in this case is a lymph node disorder. So in that case, we've got lymph node cervical swollen. Well, that would be an assumption ours is swollen, but we do have lymphadenopathy cervical. So personally, I would be happy, because lymph node disorder is a synonym of lymphadenopathy, to choose lymphadenopathy cervical. So if we look in Dorland's to reference it, to back up my feeling, disease of the lymph nodes, usually with swelling, also called adenopathy, lymphadenopathy. So it's a general term meaning a disorder of the lymph nodes, and we're able to be light. So our learning points here is you use medical judgment to understand, firstly, if an abnormality is reported. And some of you may say, well, how do we know that there is even an abnormality there? And we would say, well, take the worst case scenario. And generally in medical usage of terminology, we often see this, lymph nodes reported without actually referring to a disorder, because it's taken that there is some swelling or abnormality there when they're mentioned, because you wouldn't normally feel them in the same way. Search for all possible synonyms. We may have looked for enlarged, or we could explore the hierarchy as we did, starting from disorder, because so many of you voted for that one, the disorder. If you can capture the site of the lymph node, as I did with cervical, and it may be something that you do document, as with a number of these things, if you're unsure, if it's something you see commonly, document it, and it helps not just your current coders, but also new members who may join your team. So my suggestion there would be to select lymphadenopathy cervical with a PT of lymphadenopathy. Thank you. Any comments or questions, Caroline, on that one?
Here's the question. What about lymphangiopathy because a vessel is involved? I think the verbatim does not indicate that a vessel is involved here.
No. I would use lymphangiopathy when it's more of the lymphatic channels themselves. This is a node rather than suggesting it's part of the more widespread problem affecting the lymphatic system. So the same as that other one, that when I showed you the non-infective disorder of the lymphatic channels, it mentions a lymph node, so that's where I would focus my search, around the lymph node. Have you got anything else to add, Caroline, to that one?
No more questions.
Thank you. So our second one here is the patient, or my second one, the patient developed anaphylaxis 6 hours after receiving the first dose of the vaccine. Now, I should say we've chosen a number of vaccine-related terms for you today based on suggestions that we've had, and we like to choose something as our focus topic. So this is what we've chosen today. So the first one is anaphylaxis 6 hours after receiving the first dose. What's being reported here and how can we capture it? Can we also capture what's happened, the anaphylaxis, in relation to the vaccine? And is the dose important? So these are the questions I have in mind as I first approach it. Now we're going to start with something we've picked up from the WHO training on vaccine safety. And this is explaining what's known as an AFI, an adverse event following immunization. This refers to any untoward medical occurrence which follows immunization and does not necessarily have a causal relationship. So caused by the use of the vaccine. The adverse event may be unfavorable or an unintended sign, abnormal lab finding, symptom, or disease. And within that, we've got some further breakdown classifications. We've got what's thought of as vaccine reactions, where it's the individual's response to the inherent properties of the vaccine, an injury or condition caused by the vaccine. It might be due to the vaccine or related to the vaccine itself, or to a quality issue within the vaccine. So it might be the properties of the vaccine or a quality issue. Another subset are immunization error-related reactions, and these are preventable errors that occur during preparation, handling, storage, or administration of the vaccine. The next section is immunization anxiety-related reactions. Well, these are now more, the WHO have now changed the wording, as we'll explain shortly, and you have the reference at the bottom right there. This is now referred to as immunization stress-related response. So the same concept that started thought of as being anxiety about having the vaccine, either before or after, not related to the vaccine, but maybe fear of the injection itself. And then we have coincidental events which occur after administration of that vaccine, but are not caused by the vaccine or its administration. So bear this in mind, and we're going to go through some examples now with you. Which of these LLTs would you select for the anaphylaxis example? Yeah, I'm watching a number of you voting. I'll just move on and show you where the trends are. You can still carry on. Here we are. Most of you have gone for anaphylactic reaction to vaccine. Well, there's an option we gave you there, which was, would you select vaccine adverse reaction as well as anaphylaxis, or would you just go for the anaphylactic reaction to vaccine? Because this would seem to capture everything, wouldn't it? So finally, I've locked the poll, and there we see that 68% of us think it should be anaphylactic reaction to vaccine, because that does seem to be a nice term. It captures the anaphylaxis and the vaccine. Although the word anaphylaxis is closer in wording, it's the same concept. Anaphylactic reaction is the same concept. So we can have a look in MEDRA for this. So I can go here just to double check. Anaphylaxis, I'll leave it. I'll put the word stem so that we get anaphylaxis or anaphylactic. And we see we've got 43. And if I'll tell you what I'm going to do first, I'll just put the vaccine in. Vaccine, so that we've got vaccine or vaccination, the word stem. It'll narrow it down, and here we are. We see our term anaphylactic reaction to the vaccine, and I can go over to the browser. There it is. I can look at it in the immune system disorders as a primary, vascular as secondary, and we can see there the other LLTs underneath it. Anaphylactic reaction is the PT, and we've got, that's where anaphylaxis sits as a sibling LLT. So anaphylactic reaction to vaccine is the closest there. Now, we also had a vaccine-related reaction, didn't we? Vaccine reaction. So some of you, we will show you where that term sits. Vaccine site reaction, vaccine adverse reaction. That's under the more general term of vaccine complication. That's a lot more general. So that one is one that I wouldn't be looking to pick up that one for coding unless I was working in a company where it was part of our process that we flagged all the vaccination complications for some kind of analysis. But from a coding perspective, I wouldn't be looking to pick that one up as well. I gave you the option in the polling. Would you select the two terms? And I wouldn't do that. I would go with the vaccine anaphylactic reaction to vaccine. So just a quick point here. When we had a look there, I asked you, do you think the dose is important? And I just wanted to point out with you, this is a change request I picked up just a week or so ago that's been requested for version 24.1. And you see that with the current area of vaccines being such a topical area, there's a lot of change around this. And one of the changes that is we're going to have a new LLT of vaccination first dose. So although at the moment we're not seeing adverse reactions reported within terms available in MEDRA with the dose attached to it, it may be that in future things do change, because at the moment under immunization there is a new LLT of vaccination first dose that could be used as an indication. So just pointing that out to you. So now if we were to see, well, where are we with this one? This one is a vaccine reaction and it's a product related. It was anaphylaxis to the vaccine itself. So that's what type of AFI that one would be. So the learning points on this one is that we would always code as reported. We're told it's anaphylaxis and it was in relation to a vaccine. So we capture the relationship to the vaccine. And our final suggestion is, I agree with you, anaphylactic reaction to vaccine with a PT of anaphylactic reaction. And it would be optional if your company wanted to select vaccination adverse reaction, but we wouldn't propose that from a coding perspective, only if you wanted it for internal purposes. Okay, any questions or comments on that one, Caroline? Or have you got anything you'd like to add?
Yes, we have questions. First of all, we have a question, what about the delay of 6 hours? Because often these anaphylactic reactions occur within minutes, but they may occur in a delayed fashion as well, with a delay of hours. That's the first
6 hours
and
is realistic.
Two questions that relate to the fact that we are making an assumption here, because there is no causal relationship that is reported, that is explicitly reported here. that this anaphylaxis is related to the vaccination?
Yeah, well, this is a question we talked about yesterday, Caroline, didn't we, when we were preparing? We said that. And what we agreed was we said, like, I think your comment is valid. And when I was coding in the industry, I would have had the same thoughts. When you receive reports that somebody's taken a drug and then they have an adverse event, you don't necessarily, it's a temporal relationship. It's not a causal relationship. The reason we've chosen to do this like this now is because anaphylaxis and the time lag we thought was realistic for having an anaphylactic reaction. You're right, often it may have been sooner, but we felt that 6 hours was realistic, it was plausible. And because we're taking again the worst case scenario, we chose the relationship to the vaccine because that seemed realistic, and it's something that you'd be looking out for after taking the vaccine. And the PT is anaphylactic reaction anyway, which is what the patient has experienced. So we haven't put it in a separate PT. We've just kept the relationship at the LLT only. Caroline, do you have anything to add to that?
Yeah. I would, because there's a plausible timely relationship to the reaction to the vaccination, I would at least suspect a causal relationship to the vaccine. And that's if you have a suspect diagnosis, you would always take it as if it was confirmed. So taking the worst case approach.
Thank you. And you're welcome to come back to us with any other comments. If anyone wants to comment, please do feel free. This is, as I say, the best we can do to make it like a face-to-face class. Anything else, Caroline?
Nothing else.
No, thank you for that. So then we'll move on to our next one before I hand back to Caroline. So this one now, we have an adolescent presented to the emergency department with a history of progressive lower limb weakness for 10 days, inability to pass urine, and intermittent lower abdominal pain for 2 days. We've got a number of symptoms reported there. About 24 days prior to these symptoms, she received an anti-rabies vaccine following a dog bite. Based on physical examination and CSF findings, a provisional diagnosis of Guillain-Barré syndrome was made. So what's being reported here, we've got a number of symptoms, haven't we? And we've got a provisional diagnosis. So what elements should we capture in coding, and how can we capture these accurately? So thinking back now, remember the diagram I showed you? How would you classify this AFI, adverse event following immunization? Is it a coincidental event? Is it a mild vaccine product-related reaction, something that we would expect? So remember the bottom left-hand box, the vaccine product-related reaction, but something which is mild and often something that you would expect to see as a result of the action of the vaccine on the body? Or is it something more serious, a severe product-related reaction, which would be more considered to be a vaccination complication rather than what we call reactogenicity, when the vaccine does its job on the body? Or would you seek further clarification? I've talked you through it. And if you're like me and you've forgotten the actual verbatim term, Caroline has kindly put it in the chat for us. So if you have a look, you can see it in the chat. You can refresh your memory of what's actually happened. Okay, so I see a number of you, 35 of you so far seem to have voted. 38, going up. Get your votes in. Now let's see how you're leaning. What type of thing? Do you think it's a severe vaccine product related, a vaccination complication? Yes, I agree with you. It's a neurological vaccine, a syndrome following in trying to clarify. You just risk annoying the reporters or not. The risk is you don't get anything, but there's not a lot to lose there. So if you want to clarify, was it shown to be related, if you can. But I think I would be with you with the product-related reaction as a vaccination complication. So what would we actually code with this then? I would do, this is what the final scores are. 50% of you have agreed that it's a vaccination complication, a product related, the bottom right hand, there it is, vaccine reaction. It's that one, the product related reaction, as we explained. So how do we code it? That's what we're interested in, isn't it? Lord, if we look in the MEDRA term selection points to consider, you see the guidance on how to handle diagnoses with and without signs and symptoms. And if we have a provisional diagnosis with signs and symptoms, we can see there the bottom right hand corner. I think, do we have, oh no, I didn't know if we had any highlighting there. Bottom right hand corner, the single provisional diagnosis with signs and symptoms. The preferred approach is to code everything, the diagnosis and the signs and symptoms. So there we would, the example, so if you look in the bottom of the table, is myocardial infarction reported with symptoms, and we code them all. So the same here, we've got a provisional diagnosis of Guillain-Barré, and we've got the inability to pass urine and the weakness and the abdominal pain as symptoms. We would of course reference, if we weren't familiar with the syndrome, we would of course reference that those symptoms are characteristic of the diagnosis, and then I would code them all. So we would refer to diagnoses as it's a provisional diagnosis. We would select LLTs for all the reported events. And this is what we have. We have then, of course, the medical history would be the dog bite. We would have the indication, if we were capturing that, would be a rabies immunization. Provisional diagnosis of Guillain-Barré, all of the symptoms reported. And Caroline and I had a chat about this, and we decided that in being cautious, we would also code the CSF test abnormal and the physical examination abnormal, because all this is what's been reported. And again, optionally, you could code it to a post-vaccination syndrome, as we know that it's a severe neurological syndrome following the vaccination. That would be your choice if you wanted within your system. Okay. So any questions on that one? Quite a lot going on in that one. We didn't go to the browser because the symptoms are quite straightforward to code.
Yeah, we again have the question, assuming that the reported adverse reaction, meaning the Guillain-Barré syndrome, would relate to the suspect drug, would be an assumption.
Yeah, we do recognize that. We do recognize that, and it's more around. So that's why we say it would be optional to code the post-vaccination syndrome. That might be something within your drug safety case. You might put that more in a company diagnosis, wouldn't you, than necessarily in the coding. But that's why we flagged the post-vaccination syndrome. Yeah. We're just highlighting for you some of the typical things that might appear. This may not be common, but it's something which could appear, and we're giving you examples. So that's something you could discuss internally and decide. You are right. We don't make any assumptions when we code. We often point that out to you in these sessions. So that would be, but then we're still looking at a provisional diagnosis with the signs and symptoms, and it's up to you if you want to link it and code it to post-vaccine syndrome. Anything else to add, Caroline, on that one? Would you like to add anything for our group?
No, other than, again, it could be a suspect diagnosis. It's known that some vaccines really cause Guillain-Barré, so autoimmune reactions in the vaccinee. So that's why you could suspect that this may be an indication for such a syndrome, and you may want to flag these cases. But this is really optional. It depends on your data entry conventions in pharmacovigilance and any other rules that you apply in clinical studies, for instance. You may want investigators to flag such cases if they suspect that this could be a post-vaccination syndrome, for instance. That's why we consider this as optional. We have another question, but it's very specific, coding CSF and physical exam in the test section. Yeah, in the test section, you would just code the test, enter the test name, but here we have results of the tests. So these are actually findings, abnormal findings, so they represent adverse events. And that's why we decided to also extract those, because it's relevant information that also CSF was investigated and that the findings were abnormal.
And we had that discussion, didn't we, Caroline? Because I initially wasn't going to code them. So we go through these examples together, just like we are with you, which is why we call it Let's Code Together. And we had the same discussion. I initially wasn't going to code them. And then we talked about the fact it was a provisional diagnosis and we decided we would. But we had that same discussion. And that's the way we came down to decide to code them.
There's one proposal here, poisoning by rabies vaccine, but this is poisoning is a different concept. So this was not reported, and it's
not a
and also again there's a comment that somebody is confused here. That on the one hand side we say that we shouldn't make any assumptions when doing coding. In this instance we are now stating that there's an option to code this to post-vaccination syndrome. So on the coder, what we show here is really like a data entry conventions that you could have, either in clinical studies by having specific tick boxes in the CRF, for instance, or by data entry conventions in case processing in PV. It's just about flagging potential cases to more easily identify those. We are fully aware that this was not reported. It was reported that there was a syndrome, yes, Guillain-Barré, but it's not fully clear whether this really is related to the vaccination. We fully agree in this instance.
We do fully agree. It would be if you were working in that area and it was your suspect drug, you might know more and you might not be making assumptions but it's again, it's worst case scenario, isn't it? You're not making assumptions, you're not passing something off, you're acknowledging that it could well be related, but we have flagged it there as being optional. I'm sorry if it seems that we're being contradictory. It's because we're getting more into your PV experience, Caroline, of entering cases and not just looking at plain verbatim terms to code.
Yeah, it's really, you have to distinguish between the coding approach. There you wouldn't make any assumptions, but if you have data entry conventions in case processing in PV, you could say that such cases, because your vaccine, like with the current COVID-19 pandemic, is not, there's not too many safety information, not really wide information about the safety profile of the vaccine, you may decide that all these cases are flagged with post-vaccination syndrome because there may be a causal relationship to the vaccine. It's a data entry conventions. And if this is then extracted, then of course it would need to be coded. It's nothing that the coder himself or herself would then code in addition by splitting this term. Just to make this clear.
No. And we wouldn't do it if it was something else completely that doesn't seem plausible or isn't known to be a problem with other vaccines, would we? We wouldn't be doing it for every single symptom or condition reported after having a vaccination. So should we move on, Caroline? I'll pass over the presentation to you now. Thank you.
Yep. Here I am back again. Thank you, Jane. In our next example, it is reported that the patient developed a sterile abscess at the vaccination site, which was diagnosed to be a hypersensitivity reaction to the aluminium, that salt contained in the vaccine. So what type of hypersensitivity reaction is this? And what has caused this reaction? And how can we capture this with MedDRA actually? The first thing we have to decide is what type of AEFI or AFI we are dealing with here. So Jane already showed this classification. So here in our example, we are again dealing with a vaccine product related reaction. There is no quality defect, but the adjuvant, which is regularly contained in the vaccine, has caused a hypersensitivity reaction. So this we know already. It's a vaccine product-related reaction. You may ask yourself, why is aluminium salt added to a vaccine at all? Well, it is an adjuvant. I found this quite interesting, that is commonly used in vaccines since now 100 years. It stimulates the immune response by keeping the antigen that is injected at the site of the vaccination. In other words, the aluminium salt enhances the delivery of antigens to the antigen receptive cells. So it enhances the immune response, and this is of course desired. And it is known that they can also cause sterile abscesses. So it's known from these aluminium salts. Let's now look again into the browser. I've looked into the one that was proposed before for the eye twitching. So the oculomotor spasm would be linked to oculogeric crisis. So this is a diagnosis. It is tonia. You wouldn't do that. So it wouldn't be. You always have to check the hierarchy of these terms in order to come to a good solution for a code assignment. But now back to our example here, the sterile abscess. So first of all, what kind of reaction we have here? Let's look for abscess and vaccination using bird stems. And here we have the vaccination site abscess and also a vaccination site abscess sterile. So if you look for the vaccination site abscess, of course, you see that this is grouped under primary stock infections and infestations because it's caused by an infectious agent, whereas the vaccination site abscess sterile is grouped in general disorders and administration site reactions. So this is important to differentiate these two terms. Now, if I now search for the hypersensitivity reaction itself, the causal relationship to this vaccine, if I enter vaccine again and hypersensitivity, I get a vaccination site hypersensitivity. Okay, there was a vaccination site hypersensitivity, but we know the exact manifestation of this hypersensitivity. It was a sterile abscess. We can code this very specifically. This is not what we were looking for. So let's replace hypersensitivity by allergy in this instance. Always check or think about synonyms when doing your searches. And here we have an option, a new option, allergy to vaccine. And it's the same PT. Again, right mouse click, go to browser in order to check what other PTs may be available under the respective HLT. The HLT is allergies to foods, food additives, drugs, and other chemicals. So here's our allergy to vaccine. It's only one, it's the same LLT, no more LLTs underneath. What else do we have there? We have the drug hypersensitivity with many LLTs underneath, but yes, a vaccine is a biopharmaceutical product, but it's not a drug actually. What else do we have? Nothing that at first sight. Here we have a reaction to preservatives. This is not what has been reported. Let's check for adjuvant. Maybe we find something for the adjuvant part and search. Nothing. Again, synonyms, excipient. And here we have something. Allergic reaction to drug excipients, or we said vaccine is not a drug, so allergic reaction to excipient would be a good option. So what these are the options that we have. So we have the drug hypersensitivity, we have the allergy to vaccine, and we have the allergic reactions to the excipient. We also have the vaccination site hypersensitivity option. So quite a number of PTs we can choose from, and allergies, of course. Let me switch back to my presentation. Here we are. And continue. So these are the terms that we just saw: the allergic reaction to excipient, the allergy to vaccine, the drug hypersensitivity, the vaccination site hypersensitivity, and the hypersensitivity, so the general term that one could choose. You see that the vaccination site hypersensitivity and administration site hypersensitivity, they are grouped under different HLT, allergic conditions, NEC. I didn't manage to get all PTs that are contained in this HLT on this screen, so that's why I have these interruptions here, but you see the relevant terms: hypersensitivity, vaccination site hypersensitivity. Now, how, having heard all of this, how would you code the hypersensitivity reaction to the aluminium salt in the vaccine? What LLT would you choose? Allergy to vaccine, allergic reaction to excipient, drug hypersensitivity, hypersensitivity, vaccination site hypersensitivity. What would you do? So most of you vote for allergic reaction to excipient, but also to allergy to vaccine and to vaccination site hypersensitivity. Thank you for your input again. Well, let's close this poll now. Well, the vaccine is a biopharmaceutical product, but not a drug. I mentioned this already. Hypersensitivity is too vague. Same is true for the vaccination site hypersensitivity. We can code the hypersensitivity reaction at the vaccination site with a much more specific term, that is vaccination site sterile abscess. So what we have in addition is allergy to vaccine and allergic reaction to excipient. So the most specific term here is really capturing the cause of the hypersensitivity by allergic reaction to drug excipients, because allergy to vaccine may relate to the active ingredient, but also to the adjuvants or other ingredients of this specific vaccine product. So allergic reaction to excipient would be the most specific term to choose. What can we learn from this? First of all, clearly distinguish sterile abscesses from abscesses that are caused by infectious agents, and capture the affected site, in this instance, the vaccination site. And finally, capture also the specific hypersensitivity to the adjuvant in the vaccine, not to the vaccine, the active ingredient itself. Derived from this, I would propose to code this reported scenario to LLT and also PT vaccination site abscess sterile, and LLT and PT allergic reaction to excipient. Are there questions, Jane?
No question really. Just a quick one. That what you mentioned, that vaccine is not related, is we don't consider a vaccine to be a drug, and it was just to clarify. Is that right? That we would code separately. We wouldn't code a vaccine to a drug term.
No,
and in most cases, Medra often has a vaccine option, doesn't it?
Yeah, it's a biopharmaceutical product, yes, but it's not a drug.
Not a drug. Thank you. That's the only comment we have on this one.
Yeah, and again, optionally, you may want to have data entry conventions in place, either in clinical studies or in pharmacovigilance, to flag these cases via tick boxes in the CRF or via data entry conventions in case processing in PV, just to flag these cases for data analysis, subsequent data analysis, data retrieval, data analysis purposes. But as mentioned before, this is an option. Next one.
I'm just reading another one. I agree that we can add some codes like the LLT of post-vaccination syndrome or vaccination adverse reaction for data retrieval, but not making assumption. But I guess would be reported to regulators. I guess that what's reported to regulators can be different from what's stored in the company safety database. Not really, is it? You don't report differently from what you store in your database. You accept that you've got a company diagnosis, which isn't coded in the same way. But do you want to comment on that one, Caroline?
It really depends on the specific situation. If you were developing a vaccine for COVID-19, for instance, and it would already be on the market, and you wouldn't be fully sure about the overall safety profile of the drug because it was not yet administered to millions of patients, but only to a few 10,000. So that's why you wouldn't see all potential adverse events yet in your safety database. So then you would be more cautious than if you would have a vaccine that is used for decades already on the market. You would be cautious and maybe decide to really suspect any event that occurs with your specific vaccine that was already observed with other vaccines. You would maybe want to flag as a potential interesting case, so a suspect case. This is what we are talking about. It's about documented data entry conventions. You have to document them. You have to train your staff accordingly in order to ensure that this is applied then consistently. And only then these events would also be coded. In the CRF and clinical studies, you could do so with a tick box in the CRF. It will be more difficult to have this in the case processing in PV, but depending on your database, you may also have options to really document your suspect diagnosis here. This is what we are meaning. We didn't want to confuse you.
Mm-hmm. Thank you, Caroline. That's great. That's all the questions we have on that one.
Mm-hmm. So here, the patient presented with a severe post-vaccination abscess with subsequent septicemia. And because of that, the hospital then contacted the manufacturer because it was suspected that there was a lack of sterility of the product. And the final result of the subsequent investigations by the manufacturer was that the previous microbiological testing for sterility had failed during the production of this specific batch. So quite a complex scenario. What has happened here? The patient has suffered a severe post-vaccination abscess that was further complicated by a subsequent septicemia. Through an inquiry with the manufacturer, it was found out that there was a quality issue with this specific batch of the vaccine. Can we now assume that the vaccine transmitted this infectious agent causing the abscess? These are the questions we would need to consider. Let us again look into the browser. So first, we would of course code the events in the patient. It would be the vaccination abscess again. In this instance, it would be the one that is represented in SOC infections because this is an infective abscess. And then we also have the complication, the subsequent septicemia. Again, it's a direct hit in MedRA. If you search for it, you will get a direct hit here. It is grouped under PT sepsis. So then it was reported that the microbiological testing of this lot of the vaccine had failed, meaning it delivered a false negative result. And instead of showing the microbial contamination of the vaccine, it revealed a safe result that was within the given specifications. So it was an error made by the manufacturer that resulted in a product quality issue. Let's do now a top-down search in SOC product issues, because this is the SOC which groups the relevant terms for the product quality issues. Here we are, product issues. It's not a device, so we would look into HLGT, product quality, supply, distribution, manufacturing, and quality system issues. It's not a counterfeit. We are not told about anything in the manufacturing facilities or packaging, physical issues, supply or availability issues, what looks, label issues, distribution. Here we have a product contamination and sterility issues, LT. So product cleaning inadequate. We don't know whether it was not a product cleaning. We only know that there was a lack of sterility of the product. Product contamination, chemical, microbial, physical. Yes, this sounds promising here. Product contamination, microbial. We don't know if it was bacterial or endotoxins or fungus. So we would keep it with microbial rather. And then is also we have a PT product sterility lacking. So these would be the options we could choose from in the HLT product contamination and sterility issues. But this was this finding that the product was lacking sterility and that it was contaminated with microbes. This was the final result of the investigation that was performed because of the complication in the patient. So previous testing failed, and this must also be captured. So how can we capture this now? Let's look again into the HLTs here, and we have manufacturing laboratory controls issues. This again sounds interesting. So here we have out of specification test results. So we are not talking about a result. We are talking about a problem, about an issue. We could either choose out of specification product testing issue, quite vague. Manufacturing stability testing issue. This is not what has been reported. Manufacturing laboratory controls issue. Again, a quite vague term. And then the manufacturing laboratory analytical testing issue, PT. And here we have some LRTs we can choose from. So about purity, potency, identity, safety, stability, sterility. Here it is. Manufacturing laboratory analytical testing issue, sterility incorrectly performed. There's also sterility not performed or documented. So let's assume that it was performed, but it failed. So it failed, it was performed, but it was somehow incorrectly performed because the final result was false negative. So this would be a good term that could be considered. But also remember the other ones, out of specification product testing issue or out of specification manufacturing laboratory controls issue. Let me switch back. You see that the terms in this SOC are quite granular as well and very specific. Most of us are not pharmacists, so both Jane and I, we also struggled with all these different terms in this system organ class. Now, how would you now deal with this specific product quality issue? Which LLTs would you select? And as mentioned already, more than one LLT may be needed. One for the failed testing sterility testing and one for the subsequent positive result that there was a lack of sterility, that there was a microbial contamination. So what would you select? Product contamination microbial, product sterility lacking, inadequate aseptic technique in manufacturing of product, out of specification test results, contamination, out of specification product testing issue, or manufacturing laboratory analytical testing issue, sterility incorrectly performed. So for the issue, the former issue with the testing, most of you vote for the specific term here, manufacturing laboratory analytical testing issue, sterility incorrectly performed. So this would represent the failed previous testing, sterility testing. And for the subsequent retest, where a lack of product sterility was then detected and a contamination microbial, most of you would select product contamination microbial, but many of you also product sterility lacking. Inadequate aseptic technique and manufacturing of product would not really, this was not reported. We don't know what actually caused the contamination of this respective batch. Maybe the raw materials or staff that did not, could be staff that did not handle this batch correctly, but it could also be environmental factors. We don't know. Out of specification test results, contamination is quite vague, because this could relate not only to microbial contamination, but also chemical or physical contamination with any foreign material. So here we are. Most of you, as I said, would choose the manufacturing, laboratory, analytical testing issues, sterility incorrectly performed, and regarding the outcome of the subsequent testing, the final testing, most of you would go with product contamination microbial. So these are now again the LLTs and PTs that I've shown you, and I fully agree the manufacturing, laboratory, analytical testing issue, sterility incorrectly performed, also for me would be the best option to capture the failure of previous sterility testing. The other two PTs, manufacturing, laboratory controls issue, and out of specification product testing issues, are too broad. And when it comes to the product, the subsequent testing and the result that there was a contamination by microbes and that the product was lacking sterility, it's really difficult. I personally, I would go with the product sterility lacking, because I would consider this the diagnosis that results from the finding of the microbes in the product. So this would be my approach, but I fully see, I'm with you that this is really hard to distinguish.
We've got a comment, Caroline, before you move that one. Kirsten is saying she feels that we shouldn't assume sterility if the test was incorrectly performed, because false negatives can always happen without incorrect handling of the test. In this scenario, we don't know. We're told that the test failed, so we read that as the test has failed, so the test is the test itself that failed. So that's why we've gone for the incorrectly performed, because we struggled too, didn't we, with some of these, which was the closest. Want to address that?
This is one of the examples where you have to choose the best approximation to what has been reported. You will not always find an exact match to what has been reported, but with this LLT, we at least capture the fact that there was a problem with the sterility testing of this product. That's the only option that we have.
Yeah, thank you. I'm asking Kirsten which she would choose. somebody else said, oh yes, we're coming to that.
Okay.
Thank you. That's all on that slide, Carol Ann.
Okay. So we are now clear about the type of IAFI that is reported here. It is a vaccine reaction, yes, but it is not caused by the vaccine active ingredients or adjuvants or other excipients like in the previous examples, but by a quality issue of the vaccine. So in this example, we are now looking at a vaccine quality defect related reaction. Just a cautionary note here: when selecting terms for manufacturing issues and test results, please be aware that usage of this terminology may differ between regions. For instance, here the FDA considers all in-process lab tests, including the microbiological tests, as part of the out-of-specification laboratory investigations. But this may be different in other regions, where microbiological testing is considered a separate entity. So please be aware of this and follow your local regulations when coding and reporting GMP-relevant test results and issues. But we are still not done with our coding scenario, because everything that we have discussed so far, with everything that we did so far, we have ignored one important aspect of what has been reported in our example. The patient suffered a vaccination site abscess and subsequent septicaemia, and it was found out that in the relevant batch, a failure in previous sterility testing occurred, meaning that the previous result was incorrect and that the vaccine was contaminated and lacking sterility. Can we assume that the infectious agent has been transmitted by the vaccine? So see the guidance provided by the Points to Consider document here. And here the highlighted section, this is relevant. In our example, it was not explicitly reported that the infectious agent was transmitted by the vaccine, although it seems fairly certain that the abscess was actually caused by its by the microbial contamination. Because we do not have a clear proof of the transmission, I would rather take a conservative approach here and select LLT suspected transmission of an infectious agent via product. It would be different if the specific infectious agent had been identified and was reported to be identical in the vaccine and in the abscess, like in the example in the PTC document here, where it was really detected that the infectious agent in the product was the same as in the unopened containers. So we don't have this information here, and that's why I would take a conservative approach. But the relationship is quite clear, so I would call this a suspected transmission of an infectious agent via product. This is why the hospital has contacted the manufacturer. The manufacturer then really found out that the previous sterility testing failed. So there is a connection between the product, the quality of the product, the missing sterility of the product, and the event in the patient. What can we learn?
Caroline, you'll be pleased to hear that a couple of our attendees had already been prompting us during that as to this one. So the suspected transmission.
Yeah.
We've got some supporters for that one already.
Good. What can we learn from this quite complex example? So first we have to capture all events in the patient, meaning the abscess at the vaccination site and the resulting complication, the septicaemia, of course. And in addition, we will have to capture the underlying product quality issues. Because most of us are not too familiar with the product quality terms, it is always recommendable to do a top-down search in SOC product issues to find the relevant terms. And in some instances, you may also consider to consult quality assurance experts in a pharmaceutical production unit for advice, or refers to the MEDRA introductory guide. You will also find some useful guidance in there. And just to let you know that the Points to Consider working group is also working on an additional section for the companion document that will actually address these terms in the future by the end of the year, hopefully. So we will get more guidance for dealing with these manufacturing terms, just to let you know. By the way, they were introduced into MEDRA due to a request from the FDA. So the FDA really triggered the addition of all these terms to the terminology in order to ensure that the terminology used for capturing product quality issues are harmonized. And last but not least, consider your local reporting requirements that relate to GMP when product quality issues are reported. So finally, we suggest to code the events in the patient to, first of all, the vaccination site abscess, the septicaemia, then in order to code the failure of the previous sterility testing by the manufacturer, we would select manufacturing, laboratory, analytical testing issues, sterility incorrectly performed, the best approximation to our reported event or finding. And we would also capture the subsequent finding that the product was contaminated and was lacking sterility by either coding to product contamination microbial or product sterility lacking. My preference would be product sterility lacking. And last but not least, we would also capture the suspected transmission of the infectious agent via the vaccine by assigning LLT, suspected transmission of an infectious agent via medicinal product. Any more questions, Jane?
No, there's no more questions there. Just as I say, the comments that about the testing, that they prefer, Kirsten prefers product contamination microbial. So that's one of the options you gave. So no other comments on that one. That is a hard one.
Yes, it is. We also struggled. We have to admit that. So here, but it's a true case scenario. So child, in the next example, we are told a child that had a lymph swelling and fever that was diagnosed as to be in post-vaccination abscess. And it turned out that it was caused by a breach of sterility during the immunization. So what is being reported here? And how can we best capture the symptoms, or shall we capture the symptoms at all and only code the diagnosis? Can we find guidance in the points to consider document for MEDRA term selection? And how can we best capture the cause, so the breach of sterility during immunization? Let us first decide what type of AEFI is reported in this example now. We were told that there was a breach of sterility during the vaccination process. We do not know what exactly happened, whether the vial or needle was handled incorrectly, compromising sterility, or whether the vaccination site was not adequately prepared. But we can definitely say that an error was made, and this error then caused the reaction in the child. So this type of AEFI does not represent a reaction to the vaccine itself or a reaction to a quality defect of the vaccine like we saw in the previous examples. But here we are looking at a different type of AEFI, an immunization error-related reaction. So a preventable error that occurs during preparation, handling, storage, or administration of a vaccine. How would you code the reported events in the child to capture the first part of the information received? So how would you code the events in the child? And here more than one LLT may be needed. Vaccination site abscess, swelling of lymph, fever, extensive swelling of vaccinated lymph. What would you choose? Most of you go for vaccination site abscess, but you would also code to the swelling of lymph or fever. And some of you also choose extensive swelling of vaccinated lymph. So we have a split opinions here. Let us close this poll. Thank you again for joining. Okay, let's see what the correct approach would be. Remember the points to consider: guidance for coding of confirmed diagnosis with signs and symptoms that Jane already has shown before. If a confirmed definite diagnosis is provided together with related typical signs and symptoms, the preferred option is to code the diagnosis only. In our webinars and face-to-face trainings, we always refer to the preferred option, but of course you can also choose the alternate option to code diagnosis and signs and symptoms. It's up to you. You have your choice, but again, document your rules and train your coders to apply these rules consistently. So we always refer to the preferred option, so we would code diagnosis only. So taking the preferred option, coding of the vaccination site abscess would suffice, because the lymph swelling and fever can be considered typical signs and symptoms of a vaccination site abscess. But some of you also voted for LLT extensive swelling of the vaccinated lymph instead. Be careful if you are not fully familiar with medical concepts represented in MedDRA. Extensive swelling of vaccinated lymph is not only an LLT, but it is represented on PT level. So this should already warn you. It represents a defined medical concept. And as you can see on the slide, it is defined as a lymph swelling due to an edema extending at least to the elbow or knee in a vaccinated lymph. In most cases, the swelling develops within 24 hours after vaccination. In most cases, it's associated with erythema, warmth, or pain. It can be caused by a broad range of vaccines. Etiology is unknown, and it appears to be self-limited and resolves without sequelae. So this is the definition of extensive swelling of vaccinated lymph. So make sure to check medical references if you are not fully familiar with a given term. In our reported case, coding to LLT extensive swelling of vaccinated lymph would be wrong, because we do not have sufficient information to make this decision. We now have clarified how to handle the first part of the reported scenario, but how would you code the second part, the reported sterility issue? Would you code it to poor quality vaccine administered, product contamination microbial, product sterility lacking, vaccination error, or inadequate aseptic technique in use of product? What would you do? Most of you are on the right track here. Inadequate aseptic technique in use of product. The vast majority votes for this LLT in the middle. So let's close this here. So the poor quality vaccine administered, poor product contamination microbial, and product sterility lacking, all these LLTs represent quality issues of the vaccine itself. But in this example, there was nothing wrong with the vaccine itself. The vaccine had a good quality, but something went wrong during the vaccination process itself. So when using the vaccine in the clinical setting. LLT vaccination error would be too vague. It could be that the wrong vaccine was administered, or wrong schedule of administration was applied, or wrong dose was given, whatever. So LLT inadequate aseptic technique in use of product best captures the error that was made during the vaccination process. Most of you were right here. So these are the learning points for this examples again. When dealing with diagnosis and reported clinical signs and symptoms, follow the PTC guidance, capture the relationship to the event to the vaccination, and clearly distinguish contaminations, sterility issues that occur or are detected during the manufacturing process from contaminations that occur during product use in the clinical setting. Any questions, Jane? If not, then I will continue. Here are the final suggestions. Select LLT vaccination site abscess and select LLT inadequate aseptic technique in use of product. And with this, I hand back to Jane. Jane, are you there? Jane, did we lose you? Well, I think we are running out of time anyway. We have reached the hour of 30 in Central European time on my clock. We didn't make all the examples that we had considered for this session. We will address those at one of the next sessions, most probably the next session. So you will see these examples and you will see how we approach them. And I will now.
Do you think we should? It's a shame we couldn't have. I'm back, Caroline. It's a shame we couldn't have done the last one in that section, but in interest of time, I think we probably need to move on. It's a shame we couldn't have done the last one.
Yeah, I could do it shortly. Try to do it very shortly.
Do it quickly, just to show people the last example. And then we do have a survey.
Yeah.
That we'll have at the end as well.
So this was your turn again, Jane.
Yes. So this one is let me take the control back and share my screen. A 45-year-old man visited an outpatient clinic with feelings of choking, palpitations, chest tightness, and tingling senses. He had no history of allergic reaction, but was worried about the influenza vaccination, which he'd received the day before. Symptoms waxed and waned over 24 hours and resolved spontaneously. So let me show you here. Can you see my screen now?
Yes.
What's being reported here? What are the symptoms that we code? Do we know the cause? And can we assume that the cause is anxiety related? So you'll remember that we showed you with the different types of APHEs that one of them was an anxiety-related reaction. Would you classify this as one of those? So I won't give you a long time because I'm conscious of people's time, but I want to show you. So we're thinking of this one being, as most of you there have agreed, agree with you, it would be an immunization anxiety-related reaction. And there we are, that's our final lock the poll, and there's the reminder on the diagram. It's now termed immunization stress-related response. So this is something for you to be aware of. Here's the latest reference from WHO. There's a bit of information there explaining why they feel that it should have changed the wording. It's a stress response rather than a single symptom of anxiety. So this is a broader concept that can encompass other symptoms, not just anxiety. But and there's some more information there about it. And if you're interested, send us a note and we can send you our references. We don't share the slides, but you can watch the recording again. So how would you then code it? Would you just look to code the clinical signs and symptoms? Encompass all the other signs and symptoms, or would you code everything? Both the immunization anxiety-related reaction and all the signs and symptoms, or would you seek clarification? What are you doing here? Here we are. I think, again, most of you there agree with us to code the anxiety-related reaction and all the reported clinical signs and symptoms. Because we can't be sure, can we? We would be missing something if we just coded anxiety-related reaction. That really would be an assumption, going to those of you who mentioned before. So I won't browse because we've got the symptoms. We'll list the symptoms at the end and explain it. A 45-year-old, here's our verbatim. We would capture all the symptoms in coding as there's no diagnosis here. We've got the feelings of choking, palpitations, chest tightness, and tingling senses. We've also got the anxiety, which we feel is realistic to code the symptoms, and then immunization anxiety related reaction. Again, the discussions we had earlier would apply here. We know that it's temporal, but we know that he was worried about the vaccine. So he does have immunization anxiety. That's the MEDRA term. I mentioned the new reference, but that's the wording that's currently used in MEDRA. That may change over time, but at the moment we don't know. That's what we have. So just a point there that I was going to make, if we had browsed, I would have pointed out that I chose choking sensation and not choking because the verbatim says feelings of choking. So when I see feelings of anything, I look for a feeling or a sensation term. We don't know that he was choking. He just had that tight throat feeling as if he was going to choke, feelings of choking. Same with, I chose tingling sensation to capture the senses, tingling senses. So just a note there. So that's where we'll leave it today. And I'll take you now to the end of this presentation, and I will give you the link to we've got our other verbatims which we gave you to practice, and I'll just show you here now. We've got a couple of slides about links to some of the resources available on some of the links available to resources on our website. So let me just and then we've got a survey for you if you can spare us 2 minutes. We will also, if you want to contact us, you can contact us through our website. There's an online contact form. There's also links to our online chat. There's our help desk email, and we have some groups. So we have a Chinese WeChat group, a Russian group on WhatsApp, an English and Spanish group on WhatsApp, and a French-speaking group. So if you want to join us, you can get news about MEDRA through WhatsApp on your mobile phone. And then here is our survey. So it should pop up now on the polling. You can link to the survey. After this webinar, you will get an email, as I mentioned, and our standard practice is to send you another survey link. Now, you might feel we're doing a bit of overkill on surveys. The reason we do this is for this webinar, Caroline and I really do want to give you what's useful. We don't just want to give you a standard presentation that we use but as a general standard coding. We want to make it useful. So this is why we ask you, tell us what we can do better in these sessions specifically. And if you've got suggestions for topics or for terms that you'd like us to address, we're very keen to hear from you. So we're going to be pulling those together from what we've received in previous webinars, and we included some today, and we'll be including some next time. So please do. That's why if you've got time to do the survey now, we're grateful, and you will receive another link if you want to reply again or to send us the same information, or you can tell us now. But otherwise, I'm sorry we're over time again, but thank you so much for your interaction today. It's been a very interesting discussion. Caroline and I enjoy doing these sessions very much. We're grateful for your input. It's lovely to meet you, especially those of you who come back to us month on month. And with that, if you've got anything else to add, Caroline?
Nothing to add.
Thank you very much, Caroline, for your collaboration today.
Thank you, Jane. And bye-bye to everybody. Stay safe and healthy.
Bye-bye, everyone. Stay safe. Bye-bye.